Hi, I'm Dr. Stuart Menakar from the Palo Alto Medical Foundation, Los Gatos Center. Welcome to Health Connections on KCAT television, Los Gatos, Montserrat. Today on the program, I have my wonderful colleague, Dr. Nidhi Jacob. Nice to see you, Nidhi. Thank you.
Nice to see you, Stuart. Thank you for having me.
Today we're going to talk about women's health. I think you're an expert in that category, so I know we have a lot to share with our viewers. I think the two of us both would believe that as much as possible, good health for all of us should be about prevention. So let's start talking about prevention of troubles in women. Where should we start with our younger women with things they should do to help for a lifelong good health?
Yeah. So I think you're exactly right. That's exactly what I talk to my patients about, is preventing problems before they arise. And one of the key things for me, especially with the younger women, is to just make sure they're caught up on all their vaccines, all from childhood, and also the HPV vaccine, which is kind of a newer vaccine that people may have heard about in the last 10 or 15 years, but it's really been shown to decrease our rates of cervical cancer, and we're really lucky to have that available. So up to age 26, that's one of the main things that I talk to my younger women about.
Nidhi, what does HPV mean?
HPV, so it's the human papillomavirus, and we've recently discovered that it is the cause of abnormal Paps, which can cause a lot of worry to a lot of people, and also it eventually can lead to cervical cancer, and some strains can cause warts and other more troublesome complaints.
So vaccinations are important. There are a lot of other childhood vaccines, as you mentioned. HPV. What else should younger women be doing to help prevent future troubles? How about nutrition-wise?
You know, at any age, every age, diet and exercise is the most, I think, important thing that you can do for your health. And exercising 3 to 4 times a week, 30 minutes a day, that's very important. Having a balanced diet, not under-eating or overeating, that's important. Also, vitamins, sometimes that if they're thinking about pregnancy, and we'll talk to them about getting enough folic acid prior to them trying to conceive, that will help with their future pregnancy.
So folic acid is the main component, or one of the main components of prenatal vitamins.
Correct.
Right.
Yes.
And so in my family medicine practice, I do see a lot of adolescents and young ladies of that age. I like to talk to them about calcium and vitamin D for bone health.
Yes.
Could you tell us a bit more about that?
Almost all of us don't get enough calcium and vitamin D either in our diet or with our sun exposure, so I do recommend supplementation if they're not getting enough, and you can get that over the counter, and they're really important for your bone health, and it's through your life. A little bit more important in older women as their bone loss starts to decrease.
But a good idea to have plenty of calcium and vitamin D as a young woman to help prevent troubles as an older woman.
Yes.
You've mentioned some things about the importance of healthy diet, regular exercise, vaccinations, maybe some calcium, vitamin D supplement. How about things that we want to make sure our patients avoid? Make sure they have healthy skin their whole life and prevent cancers otherwise.
Yeah, so sun protection is really important, using sunscreen and when they're out, from a very young age. So hopefully they've already picked up that habit. And also as young adults and older women too, it's important your whole life. The other safety things, we always talk about wearing your seatbelt, wearing helmets when you're out, on a bicycle. I always talk to everyone about safer sex and making sure that you're wearing protection, that you're preventing pregnancy unless you are desiring pregnancy. And we actually check for common sexually transmitted diseases every year in our younger women and as needed in anyone.
I want to follow up on your mention about sunscreen.
Yeah.
A lot of young ladies are more willing to wear sunscreen than men, but don't forget, get your boyfriends and husbands to wear their sunscreen as well. So all of us, I like to recommend in my family practice that all of us wear at least an SPF sunscreen each day, just in the form of a regular facial moisturizer. And it can go under makeup, or some makeup may have sunscreen in it as well, which is why women are probably better at it than men.
Yeah.
And that's good for overall health, but for those of us who are a little bit on the vain side, don't forget that wearing your sunscreen and not smoking will help keep your face looking younger. You'll age more slowly if you do those things.
And I'm glad you brought up smoking. We recommend healthy habits for everybody, and that really includes avoiding smoking. And part of that is to do with their skin. Part of that is to do with heart health later on. I really think that smoking is a very difficult habit to break once you have it. In fact, I just came from a patient who's in her 40s and said, I really want to quit. I've been trying to quit for a few years. What can I do? And I really should be done with this. And she has some risk factors for heart disease, and we're trying to work on it. And avoiding the habit, I think, is the first step, because if you and all your friends don't smoke, later on in life, you're not going to be trying to quit when you really need to.
Well, we've talked a bit about prevention so far. Let's talk now about some common problems in women that we can handle pretty easily in the office. Not real complex things, but how should women respond if they have mild common infections, like maybe a possible bladder infection or a yeast infection? What do you talk to your patients about there?
I talk to them about trying to figure out their symptoms. So some people really know their bodies really well and know what's going on if they're having a yeast infection, which is overgrowth of yeast in the vagina, or there's something called bacterial vaginosis, which is a very common infection of the vagina as well. These are both not sexually transmitted, but they can cause a lot of bothersome symptoms. So they can come in for an exam. Sometimes you can even use over-the-counter treatments if you know you have a yeast infection. There are pills and creams to be used as well. And then for urine infections, a lot of times people also know the signs. They start urinating a lot, it hurts, not much comes out, and we recommend getting a test to see what's growing and antibiotics.
Do all women with these kinds of infections need to come see you in the gynecology office, or
No,
can they see their primary care doctor?
They can see their primary care doctor. I think an exam is important, especially for the first couple times you have it, just to confirm that what you think you're having is actually what you're having.
So far we've talked about common infections that aren't sexually transmitted illness and also are fairly easily treated in the office. But unfortunately, sometimes there are sexually transmitted illnesses too.
Yes.
How do you counsel patients about this?
The first thing we talk about is prevention, and honestly, the only thing that can help decrease your risk is using a condom. If you don't use condoms, I highly recommend that both you and your partner be tested before you start having unprotected sex, and also use something else to help prevent pregnancy. The most common STDs are usually caused by bacteria. Gonorrhea or chlamydia are common ones, and we can treat those, and we also treat their partners. And then there are some viruses that are a little bit trickier to deal with because they stay with you for a long time, and I'm thinking specifically about herpes. And so for herpes, one of the signs is a painful lesion. So if anyone gets a painful lesion, I always recommend they come in for an exam so we can examine and see, does this look like herpes, or is this something that's not an STD? And every pregnant woman gets screening for STDs because we think it's important, especially we don't want to pass anything on to the baby. But I recommend screening for everyone under 25, and also anyone who has a new partner or just wants it. I think it's a great way to be proactive about your health.
Sounds like a good idea.
Yeah.
I do just want to mention for our viewers, when you say STD, or some people say STI, we mean sexually transmitted disease or sexually transmitted illness. And by lesion, I think you're referring to sores on the skin, red spots or scabs or bumps or like little blisters on the skin.
Exactly.
So as part of our discussion about prevention, you mentioned Pap smears. Would you please tell our viewers what age should they start having Pap smears, and what are the guidelines about how frequently women should have them, and some other screening things like mammograms for breast cancer detection, those things?
Sure. So a Pap test is a swab that checks for abnormal cells on a woman's cervix. And the most recent guidelines suggest that we start doing that at age 21. And we do it every 3 years in their 20s, as long as the Paps are normal. And this helps to detect future cervical cancer. So if we do detect abnormal cells, then we can treat them sooner.
And prevent cancer. It's one of our only tests to help prevent. And I also mentioned earlier the Hpv vaccine. So at all my 21-year-olds, I make sure that they are up to date on that, because that's another thing that can really help with their future health. In your 30s, we start actually testing for HPV, and we also do the Paps, and that frequency can be every 3 years. Some newer guidelines say 5 years. And you can stop doing Paps
around age 65, as long as you've had normal ones in the last 10 to 20 years. So there is a moment where you can stop.
And just to when I mentioned, Nidhi, that these guidelines you're outlining, to me, if I'm correct, I hope, these are the guidelines for how often women who are in a stable sexual relationship should have their Pap smears. Women who have multiple partners would also be recommended to have Pap smears.
So Pap testing should start at 21, regardless. But if you have multiple partners later on, we do potentially do it more frequently. Or if you have a condition that makes you more susceptible to abnormal cells, such as if you've had cancer, you're being treated, your immune system's down. Those are the kind of things.
How about mammograms for breast cancer screening?
So you might know that there's been a lot of controversy in the news. Different organizations have come out with different guidelines, but in general, and especially with the American College of OBGYNs, which I'm part of, they do recommend breast cancer screening with mammograms starting at age 40. And this can be done every 1 to 2 years in your 40s and then annually after 50. And this helps us detect breast cancers at a very early stage, which helps increase survival.
And how long do women need to continue having mammograms regularly?
The jury's still a little bit out on that. I think that as long as a woman is active, if she's in her 80s and she's active and we get a mammogram and it shows something and she can be easily treated, that we should continue doing them.
So we've talked a little bit about prevention, common infections. We've talked about screening for cancers. Let's say talking about cancer itself for a little bit down the road. But now I'd like to ask about some of those middle-age things, hot flashes, menopause.
Yes.
What is menopause?
So menopause, the technical definition is that you haven't had a period for 1 year. It usually happens around age 51. That's the average age, but it can happen in your 40s or even in your late 50s. And it can be a troublesome time for a lot of people. A lot of things change with your body. Your metabolism changes, your sleep patterns may change, and the most common complaint that I find is people have hot flashes. And so a hot flash is a sudden increase in temperature, and a lot of people get covered in sweat, and they can happen once a day, multiple times a day, and a lot of times people get woken up from their sleep because of it.
What causes all these symptoms? So what is it that happens inside a woman's body during menopause that creates all this trouble?
So basically the ovaries, which were secreting your hormones, especially estrogen, have stopped doing that. And your body's kind of reacting to the sudden loss of estrogen. And we're not totally sure what causes hot flashes, but we think that the little thermostat in our brains is not working perfectly at that moment. And so some people suffer more than others with it.
So you mentioned that menopause is when periods have stopped for a year, but what happens to periods, shortly before menopause, what we call perimenopause?
Yes, so perimenopause can last a year or longer, and it's basically the time around menopause or time right before menopause. And that's when people will start noticing maybe their periods get a little bit lighter, they start getting farther apart, and they might even start having hot flashes at that time.
So a lot of the symptoms that women think of as menopause, we actually would describe as perimenopause.
Correct.
And then when menopause actually happens, most of those symptoms go away pretty rapidly, just like the periods go away.
Yes.
But there are other complications or changes that women in menopause might experience. How about some of those? Tell us, please.
So a lot of times people will have insomnia, and that's a lot of times due to being woken up from their hot flashes. So we talk a lot about making lifestyle changes to deal with the hot flashes and also to improve their sleep. And then that can affect their memory. So we talk about other lifestyle changes to help with that, especially minimizing or mitigating stress. And then in terms of vaginal health, a lot of women get vaginal dryness, which can lead to pain with sex. So we talk about strategies to help with that.
Is it true that menopause causes depression?
Menopause doesn't necessarily cause depression, but I do find a lot of patients have mood changes, and it's difficult for me to say, are you more irritable because you haven't slept because you're having hot flashes, or is this something totally separate? So, we keep a close eye on their mood changes throughout and try all of these lifestyle changes first, because sometimes I really do find that makes a difference.
If they don't, and you say, well, gee, other things happen in lives besides just menopause and hormone changes, if someone really is depressed around menopause, do we treat that just with hormones like other menopause or other medicines for menopause treatment, or what should we do?
Well, I think that they should have a good evaluation. I always like to try therapy first, but there are medications that can help as well. And sometimes it's a limited period of time where, it's a few months or a year, and sometimes it really is a clinical depression that lasts longer.
What I hear you saying is, most importantly, we want to be able to distinguish between common changes of perimenopause and menopause and true depression.
True.
We don't want to make the wrong assumption as to what's
right. And also we want to make sure that how is a woman's life affected? Is it just something that bothers her, or is it something that's really affecting her quality of life? And that's the most important thing.
And are there positive things about menopause?
Well, you don't have to worry about birth control anymore. I think that a lot of women feel more confident and more wise afterwards. I think that a lot of people who have problems with their periods, who have irritability right before their periods, or painful cramps, heavy bleeding, stopping all that can really change someone's life. So yeah, there are.
So there are some advantages
yes.
to being in menopause after the hot flashes.
Yes.
Okay, good.
It's not all doom and gloom.
Good. That's good news. I'm sure a lot of women will be happy to hear that. So I'd like to change the subject just a little bit to a few things that we see as doctors that may happen in women after menopause, maybe sometimes before menopause, depending on, how many kids a woman may have had or things like that. I know there are changes inside with the uterus and the bladder and those sorts of things that can get to be challenging as women get older.
Yeah.
So let's talk about incontinence.
Okay. So incontinence is the involuntary loss of urine, and there are multiple types of incontinence that can happen. Sometimes women only complain about it when they're stressing their body, meaning they're coughing or jumping or exercising. And sometimes people have it all day, every day. And, there's a whole market of over-the-counter products to help with that, to help with, pads and certain inserts that you can use to help. But really, I think that a lot of women don't know that there are other options available for them. So this generally happens, there are many risk factors. So age is definitely one of them, being postmenopausal is one of them, having had children or having had pregnancies is one of them, and being overweight can also affect the loss of urine. So we have a bunch of strategies. So one of them I'm sure you've heard about is Kegel exercises. We recommend that to everybody, especially people who've given birth recently. And that just strengthens the pelvic floor. And then after that, we have non-surgical and surgical options available. Yeah.
And I want to just mention to all of our viewers that Dr. Jacob and her other partners in the Department of OBGYN here at the Palo Alto Medical Foundation are experts at both non-surgical and surgical treatment for troubles like incontinence and other changes related to what we sometimes call pelvic relaxation, where the uterus or other organs in the pelvis may change position as women get older. So it's always fine to ask your primary care doctor, and we can help with some things, but many times we turn to Dr. Jacob and her colleagues for help.
And we're happy to see people for that situation. We don't suffer.
There's good treatment.
There is treatment available, and sometimes it's just a small change can really help. And the thing that you were alluding to is the pelvic relaxation is the uterus and cervix, and sometimes the bladder can fall down, and that's called pelvic prolapse, and we definitely have options for that as well.
Right. So most people think of OBGYNs as taking care of pregnant women and delivering babies and doing Pap smears and pelvic exams, but you're actually a highly trained surgeon, and you use all of the latest technology and surgical tools for pelvic surgery related to women's health.
Definitely.
Right.
Yes.
A lot of people don't know that. I just
Yeah.
want to be sure to mention it. Let's see, are there other major problems we should address in older women after menopause? We've talked about some of the not so bad ones, right? The ones that are a nuisance, that are uncomfortable. But unfortunately, I know that sometimes women after menopause may have more serious troubles and even cancers that you would deal with.
Sure.
So can you maybe tell me about a patient you've had where you had to address some of these problems?
Yeah, so I think one of the most important things that you can tell your doctor about is bleeding after menopause. That is almost never normal, and we always want to investigate it. And that is one of the signs of something called uterine or endometrial cancer. Some of the risk factors for that are being older or being overweight or not having had regular periods when you were younger. And the good thing is, if you can call it a good thing about cancer, is that this particular one we can pick up very easily, very quickly before it progresses and becomes aggressive. So whenever anyone has bleeding after menopause, I just tell them to come on in, we'll investigate. And luckily we have good treatments for it. Other more rare cancers are cervical cancer, which we've already addressed, and ovarian cancer. Ovarian cancer is more rare. Unfortunately, we don't really have a great screening test for it. One of the symptoms is bloating and weight gain. So if you have any of that, we always recommend going in for an exam as well. But luckily, it doesn't affect as many people as uterine cancer.
So these are cancers that you would treat in your practice yourself?
We would investigate them and then refer them with an oncologist if they had the cancer.
So yes. A gynecologic oncologist
Correct.
will help you?
Yes.
And also I know that you do a lot of breast cancer screening, but probably you don't do the breast cancer surgery.
Right. So we have breast surgeons that we refer to, as well as oncologists. And if they need radiation, they're a radiation oncologist. So once you get diagnosed, there's a whole team that can take care of you.
So we touched earlier on prevention of osteoporosis, but I imagine particularly in much older women,
yes,
you see quite a bit of osteoporosis or thinning of the bones that can be quite debilitating. So can you tell our viewers a little bit about how you would address that?
Osteoporosis is a significant loss in how strong your bones are. And some of the things that we already talked about, like calcium and vitamin D, can help prevent that loss. The other thing I tell everyone is to start doing weight-bearing exercises, so not just regular aerobic exercise, but actually using weights to help. And this also helps prevent osteoporosis or help slow the progression of it. People who have osteoporosis, they have to be really careful about certain falls, like if they have a loose rug or something that they might easily trip on, we want to make sure that their homes are safe for them, because even a small slip can cause a big fracture. And that's really what we worry about, is bigger fractures in our older women. And there are medications that help with osteoporosis.
So you're telling our viewers that being sedentary, not exercising, once again, it's that old adage of use it or lose it.
Yeah.
That's true about your bones.
That's true about your
bone
bones.
strength.
Yeah, and it's a little bit counterintuitive. People say, "What? I have to lift weights? I can't just do some cardio, do some Zumba?" But yeah, really, we want you to be lifting weights. It really helps build your bones.
So we've talked about a lot of issues that are specific to women. And I know, as a family doctor, and you obviously know, in your practice, we see common troubles that affect both men and women, sometimes a little bit later in life for women than in men. But women are at significant risk for heart disease.
Yes.
Everyone thinks about breast cancer and all those terrible things, but heart disease is a bigger killer of women than breast or any other women's cancer.
Yeah.
So how do you counsel patients about the need for heart disease prevention?
So that's very important. I think sometimes a woman will only see a gynecologist, so it's important in our practice to make sure they're getting appropriate screening. We always check their blood pressure, their pulse rate. We counsel them again about diet and exercise, back to are the strongest tools that we have. And we also want to make sure that they're getting their appropriate screenings for diabetes, which can also be linked to heart disease, and educating them about the signs of a heart attack. So, as you said, we worry about these cancers and we know a lot about them, but we can't forget that heart disease is still the #1 killer of women.
So, Nidhi, next I'd like to talk about some changes or advances in care for women's health. A lot of women will remember maybe their mothers or their grandmothers taking hormone replacement every day when they hit menopause. So I'd like to ask a little bit about some changes in care about that. I know that we do far fewer hysterectomies than women used to have. So tell us about why some of those things have happened.
Sure.
Why is there a change in practice?
So let me address hormone therapy first because it's very important. So hormone replacement therapy is basically giving back the estrogen and progesterone that your ovaries stopped making. And in the past, you're right, almost everyone got it because it made people feel good. It made the hot flashes go away, and we thought maybe it would help with prevention of heart disease. There was a big study that was done about 15 years ago that came out with some different conclusions. And so now we know that hormone replacement therapy can actually increase a woman's risk of stroke and heart disease and blood clots and breast cancer. And so now the pendulum has kind of swung the other way. So right now, if a woman comes to me and she has troublesome hot flashes, we talk about the non-hormone ways to deal with it. And if we've exhausted those options, we do discuss hormone therapy, but we start with a small dose and we use it for the shortest period of time possible that she can tolerate. And I think, we're just being a lot more careful about this now. And then you also brought up hysterectomies. So 20 years ago, if you had bleeding problems, if you had pain, the answer was a hysterectomy because that's all we had at our disposal. And it was through a big incision. And so now we have a couple ways. So we can, if you have a bleeding problems, there are medications. There's the intrauterine device or IUD that can help with bleeding issues. There's something called endometrial ablation, which is a really minor procedure that can help with heavy bleeding. And then, if we've tried all of those options, nothing works, we can certainly do a hysterectomy, and we have minimally invasive ways to do that now, which is basically something called laparoscopy, where we use small incisions about a centimeter big. So the recovery from that is much easier.
It's a big advance.
Big advance.
You mentioned IUDs actually for bleeding, but one thing we haven't talked about yet is birth control.
Yes.
So let me ask you to tell us a little bit of birth control, and which for many women means hormones, but before menopause, obviously.
Yeah.
So let's talk about that.
Yeah. So how I usually counsel my patients about birth control is I say that in my mind, I separate them into two classes. One is something where you get a period every month. And if some people really want that, it makes them feel like regular. So there are the pills, the traditional pills that I think most people know about. There's a patch, which I would describe as basically like a square Band-Aid that you put on your skin and you change every week. And there's a ring that goes in the vagina. It's a little plastic ring, and that one you change every month. So those kind of simulate monthly periods. And then there are other options with only one hormone in them called progesterone. And with those options, you may or may not get regular periods. And a lot of times bleeding will slow down or become less heavy, which is important for a lot of women. So there's a shot that is every 3 months, and there is an implant. It's a little plastic, thin, a flexible implant that we can put in your arm, and that one lasts for up to 3 years. And then there is the intrauterine device, or IUD, which has a small amount of hormone, and that one can last up to 5 years. And then finally, there's a non-hormonal option, the other type of IUD that has copper in it, and that one can last up to 10 years. So there are a lot of options available.
What do you recommend to women who decided, no more kids, I'm done, but they still haven't hit menopause?
Yeah, so there are a couple options. So I prefer what's called a long-acting reversible method for actually almost all women who aren't ready to try pregnancy in the next year. And so those include the IUDs and the implant. And also some people consider the shot one of those. But honestly, if a woman is done and her periods are fine and she doesn't want to be on anything, I recommend that her partner, her husband, get a vasectomy, which is the male sterilization, which is a small procedure, very easy. We can do female, called a tubal ligation or a tying of the tubes, but it's a bigger surgery, so that's not my first recommendation.
So for short-term or reversible birth control, we send folks to you.
Yes.
And when women need long-term birth control, you send their husbands to me?
We send their husbands
or their
to you.
Partners.
Yes.
Great. Okay. Thank you for joining us today on Health Connections, KCAT Television. I'm Dr. Stuart Menakar. On today's show, we met with my colleague, Dr. Nidhi Jacob. I hope you enjoyed learning a little bit about recommendations for prevention, screening, treatment, and monitoring of all sorts of women's health issues. Remember that our OBGYNs at the Palo Alto Medical Foundation are all experts in women's health, and they work very closely with our primary care doctors to help you stay healthier throughout your life.